Hope that makes sense. Carbohydrates, emerging evidence. So carbohydrates, this is kind of where the online advice gets even more ideological. A lot of people are talking about low-carb diets, and you'll find that the keto evangelists are claiming carbs cause all the reflux disease. And others kind of dismissing any carb-related reflux disease. The truth is somewhere in between, essentially, and the evidence actually has strengthened. A prospective study in obese adults with gastro-oesophageal reflux disease initiating a very low carbohydrate diet, less than 20 grams of carbs per day, found significant improvement in distal esophageal acid and exposure symptoms. And more importantly, another randomized controlled diet intervention trial published in the American Journal of Gastroenterology in 2022 examined both the amount and type of carbohydrate. And they found that modifying carbohydrate intake led to significant reductions in heartburn frequency and severity and other reflux-related symptoms. In 2024, we had a systematic review and meta-analysis that confirmed low carbohydrate diets reduce esophageal acid exposure time in reflux patients. And so mechanistically, if a dietary pattern increases distension, gas production, or pressure after meals, reflux events become more likely. So simple sugars and fermentable carbohydrates may be part of that story in susceptible individuals. But what's the practical approach here? I don't think you should go to extreme. If symptoms are stubborn, trial reducing simple sugars, refined starches, desserts, sweets, drinks, white breads, pastries. Keep overall fiber sensible, but don't fiber bomb at night because that'll be a bulk volume. Keep dinner smaller and earlier, and you don't need to necessarily go full ketogenic. If you take nothing else from this section, night reflux is often timing and volume problem more than a macro problem. So for many people, the winning combination is smaller dinner, finish eating 2 to 3 hours before bed, elevate the head of the bed, and left side is sleeping. Part 6, food triggers, evidence versus folklore. So let's tackle the classic food trigger list, shall we? So you've got coffee, alcohol, chocolate, mint, spicy foods, big one, citrus, fruits, tomatoes. But what does the evidence actually say about these things? Well, first is, why is trigger evidence so messy? Essentially, most studies are observational and heavily confounded by BMI, alcohol, smoking, meal times, because triggers are highly individual. And because symptoms don't always correlate with measured acid exposure, some people have reflux hypersensitivity or functional heartburn. So you might look down their gullet with an endoscopy and don't really see any inflammatory changes, but they're highly sensitive. There was something called the Kaltenbach review, which I mentioned earlier, concluded that beyond weight loss and head of bed elevation, there wasn't much strong evidence supporting most dietary measures as universal fixes for reflux disease. So triggers are real for individuals, but not universal, and we can go through them one by one. The big one being coffee and caffeine. A meta-analysis found that no significant overall association between coffee intake and reflux disease. And so that's important to recognize that there was no significant association in the pooled data. The coffee is not guilty by default. If it triggers you personally, manage dose and timing. If it doesn't, don't force a ban on it because of internet advice. Next one being alcohol, and this one certainly has more support. A meta-analysis found a potential association between alcohol and reflux disease risk, with stronger association at higher intake and frequency. Essentially, alcohol has got more evidence supporting trigger than coffee, and especially for nighttime symptoms. And a 2-week trial off alcohol is often helpful in determining whether things are giving you reflux symptoms. And it'll do you a lot of good elsewhere in your body as well. Chocolates, mints, spicy foods. Chocolate's a common trigger on the internet. With plausibility physiologically, older studies showed that lower esophageal sphincter pressures changed, but evidence for universal avoidance is limited, best treated as an individual trigger. Mint, particularly peppermint tea, can reduce lower esophageal sphincter pressure in some contexts. It's plausible, again, personal trial rather than universal law. In spicy foods, evidence again is mixed. Spice may amplify symptom perception or irritate an already inflamed esophagus, but it doesn't reliably increase reflux events in studies. So the evidence for universal avoidance, again, is pretty weak. Citrus and tomato-based foods often, again, act as irritants. They can sting an inflamed gullet already, but it may not drive the reflux symptoms mechanistically, and evidence is not strong in randomized controlled trials for eliminating it. So again, use it as a trial. And then you have carbonated drinks. This has got a plausible trigger because of gastric distension and belching, and observational studies associate carbonated beverages with GERD risk, reflux risk, but causability is tricky to establish. It does make a lot of sense with carbonated drinks, and they're pretty bad for your teeth as well. So you may as well try and avoid them. So instead of banning 12 foods based on internet lists, perhaps firstly pick one as a suspected trigger, remove it for 10 to 14 days, keeping everything else stable, reintroduce and observe after 48 to 72 hours. And if symptoms clearly flare, you've earned a targeted strategy. And if it's not, you can stop restricting. And this respects the evidence. Triggers are individual. Broad bans aren't well supported. Don't live someone else's restricted diet. Part 7, supplements and over-the-counter options. What's the evidence behind them? So supplements are huge. Remember, they're not highly regulated. You don't always know what's in them. And this is where people get scammed most often. So I want to be fair on this and what the evidence does and doesn't say. Let's start with alginates. If there's one non-prescription option with some decent evidence, it is the alginates. They do this raft therapy or raft forming over the top of your food contents. It creates a physical barrier on top of your stomach contents. And there was some meta-analyses published in Diseases of the Esophagus in 2017, included 14 randomized controlled trials over about 2,000 subjects. They found that alginate-based therapies significantly increased the odds of reflux symptom resolution compared to placebo or antacids. So that had an odds ratio of 4.4. So that's not too bad. So they did help. And how do they work? They form this kind of gel-like raft which floats on top of the stomach, stopping the physical displacement of contents up into your gullet after eating. So it's essentially mechanical protection, not changing your sphincter, not changing acid production. And a 2025 study even showed that generic alginate formulations had comparable efficacy to the branded ones, and response rates were around 45 to 70%. So how do you use them? Typically after meals and at bedtime for post-meal or nocturnal symptoms, products like Gaviscon Advance contain the alginate formation, and think of it as your first line over-the-counter option. Number 2, melatonin. Interesting topic. It's secreted from GI tract as melatonin in the pineal gland, and there's some biological plausibility for GI effects. 2023 randomized controlled trial published in the Turkish Journal of Gastroenterology found that sublingual melatonin 3 milligrams per day plus omeprazole was more effective than omeprazole alone for reflux symptoms. and heartburn, epigastric pain, so upper abdominal pain, all declined significantly, more in the melatonin group with improved quality of life. It's interesting how whether this, I've never used it before with patients. So I have advised it for helping with sleep in some patients at lower dose than 3 milligrams, 1 to 2 milligrams. But it may be that melatonin is a potential adjunct in selected patients, particularly those with nocturnal symptoms. I don't think it's licensed for this use, and it's not a replacement for standard therapy. So be aware of that, and also its sedative effects. As I said, it can help people go to sleep, and it's got potential drug interactions as well. So that's new on the horizon. I haven't really used that in patients. Number 3, aloe vera syrup. Small signal in the studies, a pilot randomized control trial compared aloe vera syrup with omeprazole and ranitidine. Ranitidine, which isn't used anymore, we use famotidine now. There was a recall on ranitidine because of cancer risk. But the aloe vera group showed symptom improvement with good tolerability. So it's promising early evidence. Small studies, products, supplements like this are going to vary widely because they're not regulated. So be careful with that. Number 4, DGL or licorice compounds, often discussed in the supplement world, usually called DGL. And it's important that you know that this substance can cause things like low potassium, hypokalemia, water retention, high blood pressure. So it's not something you should just start eating loads of or necessarily going to take. We have some phase 3 double-blind randomized controlled trials, and essentially it did show better quality of life at 28 days compared to placebo. And more importantly, they showed earlier resolution of symptoms, particularly heartburn and regurgitation, from day 7 of regurgitation down to day 14. So evidence is for specific standardized extracts of DGL, but so it's not any specific, and it's not any licorice. And safety does matter a lot. I'm not recommending this stuff for reflux symptoms at all. Number 5, probiotics, enzymes, and others. There's a lot about probiotics in GI symptoms. I have to say we don't tend to use it so much for upper GI symptoms. There was a 2024 systematic review looking at probiotics and reflux across 13 clinical studies, and about 79% of interventions showed some beneficial effects with strains like Lactobacillus gasseri, LG21, and Bifidobacterium YIT10347 showed promise. So it's not going to be necessarily so easy to find those specific strains in the supermarket. But for many other popular supplements, digestive enzymes, slippery elm, DGL, chewables, apple cider vinegar is a big one my wife takes. Clinical evidence for GERD symptom control is really mixed and limited. So if you try them, treat them as an experiment. Be careful about things like licorice. One change at a time. Defined time frame of 4 to 8 weeks for probiotics we generally recommend, and stop if it doesn't have any benefit. Don't overdose on these things. Ask your doctor about it. Show them what you're taking. And for apple cider vinegar, it's a special mention because it's mentioned everywhere, isn't it? If you already have an irritated, inflamed esophagus, adding acid is probably not the sensible first-line thing to do, regardless of influences like me or anyone else, say. So part 8, 14-day reflux reset plan. So if you were to make a structured plan with your doctor that aligns with guidelines supported and high signal evidence, it's probably something like this. So day 1, food to bed gap, finish eating at least 3 hours before sleeping. Number 2, head of bed elevation, use 6 to 8 inches blocks or a proper wedge pillow. 3, left-sided sleeping, make this your default position. 4, dinner size, smaller portions, avoid big, late, heavy meals, and high fat, I suppose, high carb. 5, weight loss, if you are that type, start a sustainable weight loss approach. 6, over-the-counter options such as Alginates often help after meals or at bedtime. 7, trigger testing. Pick one suspected trigger: alcohol, carbonated drinks, mint, chocolate, spicy foods, coffee, and run a 2-week elimination diet and then re-challenge it for 48 to 72 hours. And I would add in one more thing. I have seen some athletes who get reflux, and I suspect it might be from increased abdominal pressure from whatever they're doing, whatever position they may be in, and it may be that changing exercise routine may sometimes help. But track your outcomes: heartburns days per week, nocturnal, nighttime symptoms, regurgitation episodes, rescue medication use. And if there's no meaningful improvement after a good 2-week trial, consider talking to your doctor, getting a review, diagnosis confirmation, medication timing, optimizing if you're on PPIs, and investigation for alternative explanations. In fact, I would think about doing that in the first instance if you're getting reflux, rather than going through all of that. So closing the few things that matter, I'll leave you with the bottom line. If you want symptom relief using the best available evidence, prioritize your weight loss. If you're overweight, single best lever, head of bed elevation 6 to 8 inches, not with stacked pillows, left-sided sleeping, avoid eating close to bedtime 3 hours, using alginates, figuring out your personal triggers. And I hope this episode helps. Share it with people who also get bad reflux symptoms. Make sure that people get checked by their doctor. There are other things such as hiatus hernia, strictures, eosinophilic esophagitis. There are other things that need to be that can be diagnosed if symptoms not getting better. Brilliant. And until the next episode, I'm Dr. Kash Gupta. Hopefully, this has been of some help. I hope you enjoyed the Liver and Guts podcast. We'll see you in the next episode. Thanks very much.